introduce our two speakers. First of all, we've got Dr. Jamie Fleming. Dr. Fleming is a Phoenix native and serves as a section chief of pain medicine and director of interventional pain here at Phoenix Children's. She graduated from Barrett Honors College at Arizona State University with a degree in finance initially, and then subsequently completed a post-baccalaureate research fellowship at the National Institute of Health. She earned her medical degree from the University of Arizona College of Medicine, where she was inducted into the Gold Humanism Honor Society. She then completed an anesthesiology residency at UMass Memorial Medical Center, where she served as chief resident and developed a leadership curriculum for the residency program. She went on to complete fellowship training in Colorado at the University of Colorado in Colorado Children's Hospital, where she did pediatric anesthesiology and adult and pediatric chronic pain. She's board certified in anesthesiology, pediatric anesthesiology, and pain medicine. Her clinical and academic interests focus on advancing the field of pediatric pain through innovative interventional approaches, multidisciplinary care models, and the development of programs that expand access to specialized pain care. She's published in journals including Pediatric Anesthesia and Fetal Diagnosis and Therapy. And outside of medicine, she enjoys international travel, running, and weight training, great coffee, and discovering exceptional dining experiences. She'll be accompanied today by Dr. Sean Gamble, who is triple board certified anesthesiologist, specializing in adult and pediatric anesthesiology and pain medicine as well. He's nationally recognized as an expert in regional anesthesia and interventional pain management, particularly for complex pediatric and cancer-associated pain syndromes. He completed his residency at the University of Missouri, Kansas City School of Medicine, followed by advanced fellowship training at Children's Hospital Los Angeles and Harvard Medical School, where he trained at Boston Children's Hospital, Brigham and Women's Hospital, and Beth Israel Deaconess Medical Center. Dr. Gamble previously served as the chief of pain medicine here at Phoenix Children's Hospital, where he led transformative initiatives that advanced acute and chronic pain management protocols and expanded access to innovative therapies for pediatric pain patients. During his leadership, he founded the International Pain Medicine Program and launched the country's first and only dedicated ambulatory pediatric interventional pain suite. In 2025, he founded Noble Medical Professionals, a national consulting and educational platform dedicated to elevating health care through transparency, integrity, and high-quality education for both patients and providers. Through his work, he's committed to bridging the gap between knowledge and practice, empowering better decision-making and improving clinical outcomes. Dr. Gamble also serves on the medical advisory board of HEAL Clinical, an organization focused on advancing patient-centered clinical research, improving access to innovative therapies, and optimizing outcomes through data-driven evidence-based care models. As a key opinion leader of the Avanos Medical and Project Medical, he plays an active role in shaping the future of pain management technologies. A passionate educator, Dr. Gamble regularly teaches providers across the country safe, precise, and effective techniques in regional anesthesia, reinforcing best practices that enhance patient safety and elevate standards of care. So without any further ado, Dr. Fleming, take it over.
Thank you. Thank you so much for the introduction. We're so excited to be here. I'm Dr. Fleming. I'm the current section chief for pain.
Sean Gamble. That was a lot of things. Thank you. I forgot I do all that.
And we're here today to talk to you about who we are, what we do, and why we're so passionate about our field. And hopefully some of you may even go into it after chatting with us today. Both of us are fellowship trained in pain medicine. We're both board certified in pain medicine in addition to pediatric anesthesiology. I don't have any disclosures today.
As you kind of heard, I do a lot of things outside of practice pain medicine here at Phoenix Children's. And so a couple disclosures, I am a KOL for Avanos. I'm on the medical board for HEAL-O Medical. I'm a second MD consultant nationally. So I provide consults for kids around the country who, as you'll see, have no access or very little access to interventional or chronic pain management physicians like myself. And then I also own Noble Medical Professionals, and then a new company we started this year called Sedicare. Hopefully we hear a lot more about those in a couple of years. But we're not talking about any of that today.
So there's several things that we're going to touch on today and really want to drive home to you as a listener. We want you to better understand interventional techniques that are out there for pediatric pain, what kind of patients are good candidates for those things. And also just know a little bit more about our field. Our field's small. It's very in its infant stages. It's growing really rapidly. It's evolving rapidly, and it's a very exciting time to be here. It's always good to start with a patient story. I think that has the most impact. And so why not hear it from a patient themselves?
I went to the first baseball practice. I started swinging and I felt fine. I just felt rusty because I wasn't loose yet and I didn't stretch. I woke up and I couldn't move my back or move really at all, like at all. We went to the emergency room. I was crying in the waiting room, hoping that they would get me in fast enough. They said I was probably exaggerating the pain. It was probably nothing bad. It was probably just a torn hamstring. Kind of felt like, no one believed me. No one believed my pain.
He couldn't go with his friends. He couldn't jump on a trampoline. He was hurting. He couldn't do the things he's done his whole life.
We got an MRI like a month later because the insurance wouldn't let us get an MRI. They just said, I'm fine. I don't need it. It wasn't fine.
So we'll get back to Dalton's case in a bit. When Sean and I were looking at this presentation and making it, we really sat back and reflected, and we were like, wow, we've gone so far in just a few years. And we're pretty ourselves astounded at where we are today. And it's always been a very improbable path. So many things had to align right. We had to have the right people, the right situation, the right environment, and the timing to get to where we are. And we're going to tell you a little bit about our personal stories too, which is maybe a little more interesting than dry medical stuff. But it all started with a phone call. And this is me. This is me back when I was a resident at UMass Memorial Medical Center. That picture is me when I was a resident. And I had just done my pediatric anesthesia rotation. I did not expect to love it. And I unexpectedly was like, wow, that was amazing. I really enjoyed that. Maybe I should look into doing this for my life. And then the next month I was over in chronic pain, as adult pain, but I said, wow, the clinic's a little rough, but the procedures were awesome. They were so much fun. Like, it's really cool to improve functional outcomes and help people get their lives back. And I really started feeling torn between the two specialties and started to think like, is pediatric pain a thing? And I knew no one in that field, had never really heard of the field, and thought, okay, maybe I should look into this and get some information. So I cold called our friendly neighbor, Boston Children's. And who do you think was on the other end of that line? Dr. Sean Gamble. At the time, he was at Boston Children's doing his pain fellowship. And he and I got on the phone. We spoke for about an hour. He just was, I don't know if you've met him before today, but he's like such a charismatic, engaging person, so excited about his field. He could feel the energy through the phone. And I was like, whoa, I was like, I want to be like that guy. I want to do what that guy does. He was so excited about it. And it just like then and there convinced me to commit to doing not one, but two fellowships, for going 2 years of attending income. But, I have no regrets. So I'm very thankful for that. And, the story didn't end there, obviously. He graduated from fellowship. I went on to do my fellowships. And then years later, he recruited me to come back here. And I'm from Phoenix originally, so it was an easy choice. But now we get to work together all the time. So we're going to circle a little bit back to some more broader topics. And why should you care about pediatric pain at all? And I think the thing that a lot of people don't realize is how common it is and how undertreated it is and how it affects so many things in the long run for families and children. About 1 in 5 kids have chronic pain. And so that's actually much more common than a lot of people realize. But there's very few programs that treat it. When you look nationwide, there's less than 50 of them out there. Fellowship programs that train people to do pediatric pain, also very few. It's less than 10 around the nation. And all these clinics have crazy wait times, months. So, it's tough when you're dealing with a kid not going to school, not functioning well, and then they're waiting months to even get in anywhere. So the fact we have this program here that's comprehensive, and we do more than interventional pain. We have a great multidisciplinary program and a lot of other basic blocks that really help us treat these patients well. Our program is really great for this community and regionally. We get people that come from other states to come to our program. And where do we fit interventional pain into pediatric pain care? So we're going to do this in kind of a pyramid. So the foundational level, the biggest block and the main important thing is functional status. So that's physical therapy, occupational therapy, pain psychology, dealing with things going on at home, coaching, focusing on functional goals. And that's really the foundation. And a lot of our young patients do very well with that when that's in place. Sometimes other things are needed. So then we progress on to medical management. Those are things like medications, also other integrative therapies. Then we start to get into the interventional space. So there are less patients that are candidates for these things, but they can be very effective in the right patients. We do everything from more basic interventions like trigger point injections, headache blocks, to other kinds of nerve blocks, things in the spine, sympathetic blocks. And then finally, we have our advanced interventions, which we do here as well. Those are things like implants, spinal cord stimulators, peripheral nerve stimulators, intrathecal pumps, nerve ablations, those kinds of things. And, I hope one of the messages you take away from this is how new this field is and how we're just developing it. And this is one slide to show that. Really, pediatric pain wasn't even a thing that people thought about until fairly recently. It was in the 80s that people started paying attention to it and realized, like, oh, we do have to give proper anesthesia to neonates and those kind of things. It's because our nervous systems remember things, even if we don't consciously remember it. It makes a difference later on. And then in the early 2000s, we started getting the biopsychosocial programs that really focused on functional restoration, and those are the mainstay still today. And then over time, we started building a little bit of these targeted interventional approaches, but it's so recent. It's been only about 10 years that this has even been a thing in pediatric pain. And, why is that? There's a lot of barriers that we're going to walk through. And I think this also shows why our program is so special. First of all, it's a small field. There's not a lot of people out there. We have a fair amount of people that have been in the field for quite a long time and aren't familiar with these strategies or trained on them. So there's a lot of resistance in the field to adopting some of these techniques for various reasons. I think there's some concern too about utilizing these instead of the basic blocks that we know work, like the functional restoration and the multidisciplinary programs. But that's not what we're advocating for. Ours is more of an adjunct to those things, not an thing to utilize instead. Because there are not many programs doing this, not many physicians doing it. There's not a lot of studies. We have some case reports, but we don't have large scale data on these things that we're doing. And the institutions that do these procedures, and there's not many, they don't really publish their procedural data, their numbers, their complications, their indications, all those things. So you're really just out there in no man's land trying to kind of piece it together for yourself. When you look at the way we're trained, so both of us went to a interventional training program that does pediatrics and adults. We have to do some adult to get the volume to be able to do these procedures, where our adult colleagues do adults all year. And so you can imagine when we're in the pediatric space, we're doing less procedures in our training than our adult counterparts. And so what happens a lot of times is people get done with fellowship and they're not comfortable doing the interventions, especially, stims and pumps and those more surgical based things. And, you have to really go out there and get it if you want to do it. You have to go to, other spine courses, keep learning. You need to expose yourself to these things. And I think it's very uncomfortable and you have to put yourself out there and it's hard. It's not easy for people to do that. And then finally, lack of peer support and institutional infrastructure. So if you then graduate and you have the skills, but you go to a program that you have to build, and they don't have the right procedural support. They don't have other peers there that do those procedures. You're on an island alone, and it's scary. So there are a lot of people too that get there, they do the training, they go into the field, and then they find that their skills regress and they're not comfortable doing a lot of these things anymore. So these are one of the reasons why, we're kind of a unicorn here with the two of us. We try to look at a data of how many people out there are like us, and it's really not many. So we asked ChatGPT, and we're like, how many board certified pediatric pain people are out there? And it said, like, realistically, probably 50 to 100. And then you look at that group, and probably less than half of those do any interventional stuff. So you're looking at less than 50. And then there's a big spectrum in the people that do interventions of what they're capable of doing. So, really, there's probably, I would think, maybe less than 10 people that do the kinds of stuff that we do. And there's two of us here.
Yeah, no, that's a huge number. I think it's like something to reflect on for a second, because we realize that, right? And us realizing that last night and realizing just how rare this is, the fact that we are here doing this together, is so unique, because having less than 10 providers capable of offering the services that I think the majority of your patients will probably benefit from at some point in their life if they suffer from chronic pain is astounding when you talk about a country of over 300 million people. So yeah, it was pretty amazing to kind of realize that. And this is all right here in Phoenix, right? So everybody's heard of Boston and Cincinnati and these other big programs. And honestly, we're doing it in bigger ways than some of those big name programs. So it's pretty cool.
Yeah, and the great thing too is, since there's two of us here, we can do more than we could do alone. Like, I would be much more hesitant to take big risks and do some of these advanced things if I didn't have backup and support. So it's been very instrumental to the growth of our program, just that there's more than one of us here. This is going over that point again, that interventions are really underutilized when you look at the national landscape. So the critical shortage of physicians trained, we just went through a lot about that. Most of what we do is off-label and not FDA approved. So all of these devices we're talking about, none of them are approved under 18. Everything we do is deemed experimental by insurance companies. So we spend a lot of time on the phone with them doing the dreaded peer-to-peer, talking to the insurance companies, trying to convince them why they should reconsider these things. And it's hard. Again, the data is an issue. There's no RCTs for pediatric nerve blocks and other interventions. So, there's not a lot out there to support it objectively from a large study. And even when you look at big programs, we're looking into, okay, these big programs, how many blocks are they doing? When we're looking at studies of large cancer centers, one of the largest cancer centers over 10 years did just 27 blocks for cancer patients. So even these big capable centers that see a lot of this aren't doing it enough. So, the point is really that most places that do any of this are very low volume, and very few have the advanced stuff that we can offer here. All right, and now the fun part, getting back into our program. Now that we lay the groundwork of what it looks like out there, we can talk a little bit about our program here at PCH. So right now there's 3 of us in the interventional pain space, myself, Dr. Gamble, and Dr. Singhal. Together, we're less than 1 FTE dedicated to pain. So we split time between anesthesia and pain. Our time split between doing clinic and doing procedural time. So Dr. Gamble and myself spend about 5 to 6 days a month in the pain world, and Dr. Singhal does 1 to 2 days a month. And even though, today we're talking about how fun this has been in the journey, it's been, the foundation for this was laid years and years and years ago. So we're going to walk through the history of that as well.
Yeah, so long before any of us, including myself, some of the innovators that kind of started the foundations of the pain management program here at Phoenix Children's had the insight and the foresight to think that interventional pain was going to become a thing. And so right around the time that I was completing my residency in 2016, Dr. Jones, German, Hansen, Kuhn, and Singhal began recruiting for an interventional pain physician. At that time, there was absolutely no infrastructure to offer interventions to pediatric patients here at Phoenix Children's. And, we were not Phoenix Children's Medical Group anesthesiologists. We were private practice with Valley Anesthesia. And Valley Anesthesia had a pain division. Now, these were adult providers who had very little to any comfort level, managing or let alone injecting children, right? Because as you remember back in 2015, it was kind of like a very taboo, but at the precipice of discussions about offering interventions for children. And yet there was one partner, Dr. Balampali, who got credentialed here and intermittently would come over and do 1 or 2 injections a year on very clear cases that were refractory to everything. Fast forward a couple of years, and that crew had attempted to recruit some physicians who were very early on starting these fellowships out. And at that time, fellowships were non-ACGME accredited, or if they were accredited, you were doing 50% pediatric medicine, 50% pain medicine, in order to get the numbers to qualify to be able to take the boards. So a couple of docs had been approached about coming and joining Valley and taking on this role of really beginning an interventional pain program and developing into what it is today. And thankfully for me, they all turned it down. In 2018, and I was a Canadian on a J1 visa, so talk about extra barriers. They approached me, and I came out and I interviewed. I met the entire team and saw the hospital. I saw the potential, and I saw the catchment area, because we're in the Southwest and there's nobody doing this over here. And I was super excited, as Jamie told you, about all the things that I was learning and doing in Boston. I had this dream of joining here and creating Harvard of the West, right? And bringing what Harvard had to the West and the Southwest specifically. And so some of the folks helped me jump through a lot of hoops and barriers and get my J1 waived. And I became an H1B, thanks to Governor Ducey, and thanks to PCH sponsorship. And here I am. So I joined in 2018, and I took over the pain program as a whole in 2019. And in early 2018, 2019, there was no intention for interventional pain to even exist. But the current pain provider, Dr. Genovese, started curbsiding me and asking me if, hey, would this kid benefit from a block? I don't know much about blocks. Teach me about blocks. And it was kind of one-off cases. And between 2018 and 2019, we decided that there was a need for interventional pain to become sort of a sidestep or an adjacent to the foundations of multimodal pain management, which you all know are so fundamental to managing complex pediatric pain. And between 2019 and 2023, we just grew, as we'll show you in a little bit. Started off, as Jamie said, coming to a facility that had absolutely no infrastructure in place to let alone take a patient, because we just weren't doing it here, right, at any regular rate, to take a patient from the clinic to the operating room. Half the time, they don't even need anesthesia. So in a pediatric environment, everybody gets anesthesia. Right? I mean, it's very rare that anybody does anything awake, right? Think about your own patients on the floor. I'm sure they'd rather get their IVs asleep, right? So imagine pain procedures, surgeries, all of those things are usually done under anesthesia. But, we didn't need that for everybody. So we had to build everything from, the order sets, the authorization process, all of that to get kids even into the operating room, to get the injections they needed. And then we had to figure out how to, fix our mistakes, do it better, be more efficient at it, and build. And we did that for several years. Thankfully, in 2023, right after we joined at PCMG, we were able to recruit Dr. Fleming, and the volume that we had perceived based on the numbers of 1 in 5 children, 20% of every patient you'll touch, see, or have a contact with has some form of chronic pain, right? And we're in a city of 6 million people, right? If you include everybody around here. So I could not do it all myself. Dr. Fleming coming and joining the program was absolutely instrumental in 2023. And then in 2025, after doing it for a long time, I decided that the administrative leadership building phase of my life was going to be over, and I encouraged Dr. Fleming to step into that role, and gratefully she did. So in 2025, we handed off the baton, and she took over as chief of pain. And in 2025, we were able to open what I think, for me at least, has been one of the most proudest moments of my career, which is the standalone pediatric dedicated interventional pain procedure suite, the only one of its kind in the country. So we'll show you that in a second too. And now in 2026, it's exciting. Under Dr. Fleming's leadership, we're starting to train our nurse practitioners to do the simple procedures like trigger point injections, pericranial headache nerve blocks, SPG blocks, things that we'd like to train other providers too, in the ER, in the neurology clinics, in the palliative care setting, to be able to do and offer their patients. Because we are only 2 people, plus Dr. Singhal is not here. Thank you, Dr. Singhal. So the only way we can reach everybody is by helping you all do these things with us and partner with us. And very, very exciting in 2027. We can't say any more than this. Stay tuned, but we have another interventional pain provider joining our program, which will officially make us powerhouse in the country, right? I mean, that puts us on par with Boston Children's. So in 10 years, I feel like I've kind of realized my dream, and I got chills saying it just now. So it's awesome to be able to share it with you all. So what we have built, we've got this dedicated interventional service, right, that pairs along with the comprehensive pain management service. We've built procedural infrastructure, right? We've started off with just seeing paired one-off interventional visits, evaluating your patients for where we could target our needles and where we could give additional pain relief outside of the refractory cases where medical management, psychology, physical therapy, and rehab fail, right? Or where we could use these things as adjacents to. All of that had to be built. And we've integrated it very seamlessly with a multidisciplinary care team. We are never in lieu of, we are in addition to. We're the cherry on top. When we're always looking for opportunities to do these things, but these are not fast track, quick fixes, silver bullets. It doesn't work that way, unfortunately, in pain medicines will feel. And we have our peer support now. So that's been so valuable to Dr. Fleming and myself and our whole pain team. When we were first initially building this as a private practice in a children's hospital, it was a sticky situation. And we had a lot to navigate, and there were a lot of challenges about pain management, like, to justify that, how do we keep an anesthesiologist out of the operating room? That's what he's supposed to be doing, is the anesthesia, right? And creating this thing required a lot of support from our leadership and our peers back then, and we have that solidified now, especially with our team and our managers. Our Kendrick, who's here supporting us right now, and the rest of the anesthesia of the week folks and all the managers, our clinical and our leadership, administrative staff, everybody supports us. And that's, super powerful for what we intend to do moving forward. So thank you guys all. So without further ado, another little video. I want to show you a little bit about what the interventional suite is and why this is so fundamental and monumental for what we are able to do.
What gets me super excited about doing this work is, seeing the look on a kid's face when they feel better, essentially. I mean, that's ultimately what it's about. This interventional pain suite is revolutionary. It allowed us to really expedite the care that they already need and improve our turnaround time and get them back to their quality of life that they need to be in a quicker time frame. It also allows us to flex kids back quickly when they need a second procedure, or if they end up in a pain crisis and they need something done to try and get them back into school, keep them out of the ER, keep them out of the hospital. So we do this in a comprehensive fashion, making sure that we're leaning on all pillars of our specialty to give the patients the best outcome and give them their voices back.
So if any of you have been in the OR, you saw that room kind of looks a little bit like an OR, right? It's a non-sterile version of an operating room. We were very fortunate enough a few years ago when the hospital moved us from our previous interventional suite. We were doing all of our evaluations, maybe some trigger points and some easier sort of lower risk things to this new space. And when I was chief at the time, I kind of felt like we were being pushed off into the corner a little bit. But as I walked that corner, I saw the old ER trauma bay. And at that time, I thought this would be the amazing, this would make the ultimate interventional pain suite. I wonder if we could make a case and a business model to be able to take our kids out of the operating room, right? And maybe bypass some of the infrastructure that we had created that were also barriers to, being able to meaningfully treat patients in a timely fashion and take them into this room, and we could create this space. So we started working with the Children's Hospital, the whole group, and kind of convincing them and making an argument for the fact that we didn't need to take everybody to the operating room. The operating room was fantastic, and it's still a tool we utilize a lot, especially when kids need deeper sedation, max, or we're doing surgical procedures like fully sterile implants and pumps and a lot of the more advanced things that we do. But for some of the easier bread and butter things that we do, we didn't need to wait 8 to 12 weeks, which was the wait time to get into the operating room for a child. So, how do you sit down and have a conversation with somebody and tell them that I can do this injection for you that'll take 15 minutes with an x-ray table, but you got to wait 12 weeks because that's the only time I can get to the operating room, even if they don't need the sedation. So we built this case, and while it was going through all the committees, I started making friends with everybody and around the hospital and just collecting things that I knew that we would need. Old operating room tables that we could repurpose and fix, and monitors for putting on the wall. And we got the folks to come in and paint it like pro bono. I don't know how we got that one done, but we did. New curtains and things, right? And essentially, when we opened this thing up on the day after Canada Day, which was really cool, July 2nd, 2025, we were ready to go. So we got approval, and the hospital came to us and said, okay, it took 2 years believe it or not, to move this mountain. And when we finally got approval, we came back to us and they said, now what do you guys need for a budget? And I was like, that's the best part, guys. I need $70. And they're like, Gamble's lost his mind. And I was like, no, I haven't. I collected everything that we need to open up. And I was just going to ask for forgiveness if it didn't work out. But I need $70 for a pair of gold scissors and a ribbon because we're ready to go. Let's go. And we did. We started interventional pain here in our clinic. Feel free to come by if you ever rotate with us. Come check it out. Lay eyes on it. It's an absolutely astounding, amazing space, as you saw in the video, that didn't exist and really doesn't exist anywhere else. So just more validation that what we're doing, we care about, we're passionate about, we want to take care of our kids in a timely fashion. This allows us to do that and get them better quicker.
What gets me super excited about doing this work is
We're listening to it again.
Sorry.
There we go. All right. So these are some of the fun slides. So we work together all the time. We do a lot of cases together. When we do hard cases, we do them together. And that peer support has been absolutely amazing and has allowed us to do so much more than we could do before. More pictures showing our friends coming and supporting us, helping us out in there. We're going to conferences and presenting. We're trying to get our names out there, trying to show what we're doing and have people understand that there's a lot more that can be offered for these patients. So, we've gone to a variety of conferences in the last few years, some internationally. We went to Marrakesh, we went to Scotland. We were at the Society of Pediatric Pain Medicine meeting this year and last year. We're teaching ultrasound courses and doing all kinds of things. So we're trying to do our due diligence in those spaces as well. And most importantly, we also have fun and get to know each other as people. So I think that's been instrumental to our team dynamic and achieving more in the clinical realm. This is some data. I pulled together some data regarding our clinic and procedural growth over the years, just to show you. So this is data for the attendings that see patients on interventional pain. Dr. Gamble can probably speak to this, but 2018 was kind of those one-offs he was talking about where people were kind of curb consulting him, but didn't really have any formal way to see them. In 2019, we started getting real referrals for interventional pain. So that's when it started to pick up. These red blocks are the new patients. So over time and projected for 2026, we're seeing more new patients almost every year. We have transitioned some of our follow-up care to our nurse practitioners. So that's why the attending follow-ups have decreased a little bit, but overall very strong growth since 2018. This is our procedural volume from 2018 to 2026. So huge growth there. I started here in 2023. So between, having another provider, we were able to do a lot more. And this is projected for 2026 based on our Q1. But I think we're going to keep going up.
Yeah, no, pause on this for a second. We think about, where we started and where we are. If that was a stock ticker, you'd buy now, right? And if you can imagine, we have another interventional pain doctor coming. And so this just speaks again to the volume and the need for these interventions. And, we're not offering needles and injections and therapies like this to everybody, but when we select patients appropriately, you can see that the small percentage of patients that are suffering from chronic pain who benefit from these do extremely well. And by adding a third interventional pediatric pain provider, we expect this number to kind of even, or this curve to continue to boom and bust here at Phoenix Children's, which is amazing because it's setting a trend nationally and we're leading the country in this.
Yeah, and again, none of us are doing full-time pain. We're all splitting our time in together less than one FTE.
So let's talk a little bit about what we do and how we can kind of help your patients. And then we'll talk about some cases that some of y'all may be familiar with. Then we'll have time to, answer some questions and focus on some of the unique aspects of interventional pain management. So, this is kind of a hierarchy of things that we've been trained to do and that we've offered here at Phoenix Children's and that we've worked really hard to maintain our skill set in. The bread and butter, I would say of an interventional pain provider is doing nerve blocks, right? And as you'll see in a slide later, I kind of like to think of myself as like the Oprah Winfrey of injections. You get a block, you get a block, you get a block. And every time I evaluate somebody, I'm trying to think, where is the pain generator coming from? If you remember back to pharmacology, local anesthetics, they're sodium channel blockers. right? Sodium channels are highly important in conduction of action potentials from nociceptors to the brain. If I can put a sodium channel blocker on a nociceptor and shut that pathway down, just like a light switch, then that gives me great ideas about what I can do long-term. So nerve blocks is our bread and butter. We use interventional techniques with ultrasound and x-ray to make it safe and efficacious and to decrease our risks. It requires a lot of time and skill and a lot of expertise in anatomy. So we have to work at that a lot. And then ablations is something that we do a lot of here in the country. We may also lead the country in this. We're unsure, but if we don't get the benefit of long-term pain relief from an intervention of local anesthetic and steroid, we may then step it up and offer an ablation. That could come in the form of cryoneurolysis, as we'll talk about later, RFA, or chemoneurolysis, where we're actually destroying or partially destructing a nerve in the peripheral nervous system temporarily to give prolonged disconnection from the brain. Stepping up from that, we do some neuroaxial blocks and catheter placements. So these are the things you may think about in your family members or friends or colleagues who've had pain management. Epidural steroid injections, transforaminals, lumbar sympathetic plexus blocks to treat CRPS and other sort of complex pain-mediated syndromes. Catheters, epidurals. Every anesthesiologist thinks about, or you probably think about anesthesiologists putting in labor epidurals. Well, this is labor epidurals on steroids, pun intended. Neuromodulation, spinal cord and peripheral nerve stimulators. This is where I think in terms of the country, we're probably one of very, very few providers who will use neuromodulation and peripheral nerve stimulation in pediatric patients. One of my goals when I was learning about all this in 2015, just as the field was kind of up and coming, was to figure out ways to adapt therapies that are FDA approved, evidence-based in adults, and use them in my pediatric patients when appropriate. And neuromodulation and peripheral nerve stimulation are extremely exciting modalities that do that. So without getting into the weeds of what that is, it's a very small subset of what we do, but it's an extremely powerful tool and very important and very up and coming in sort of our field. Other surgical type pain procedures that we're capable of providing: minimally invasive spine kyphoplasty. Do you guys know what that is? No? So if there's vertebral body fractures, we can go into the vertebral body percutaneously and augment the shape of the vertebral body, restoring its normal anatomy, and then fill it with cement to keep it from breaking down or refracturing. This may be important in pediatric cancer. This may be important in osteogenesis imperfecta. This may be important in other bone mineralization diseases. But this is something that we're capable of doing. Typically this is thought of as a neurosurgical intervention, right? We're anesthesiologists that practice pain management, but this isn't our skill set. We do intradiscal procedures as well, mild procedures. So minimally invasive ligamentum decompression for spinal stenosis, BVNA ablations, and other interspinous space replacements. So minimally invasive posterior fusions or posterior spinal decompressions. You have patients who have single or multi-level pathology, but they don't need the big spinal fusion from our orthopedic partners. There are interventions surgically that we can do to decompress them. And so we've gone above and beyond and sort of sought out that training to become certified and to be able to offer these therapies. We don't offer it often, but we want to be able to do so when we need to. And the last thing that we do, which is very specialized, is called targeted drug delivery. Some of you may have been on the palliative service or on the oncology service, and you've dealt with cancer patients or patients in intractable pain with never-ending escalating doses of opioids, right? And no matter how much you give them, it never seems to get better and their side effects get worse. Targeted drug delivery is a system that allows us to implant essentially refillable port systems that deliver medications directly to the spinal cord, bypassing first and second metabolism, giving very, very small doses directly to the central nervous system. We can combine drugs like opioids, neuropathic pain relievers, local anesthetics, antispasmodics. You ever seen a patient with a baclofen pump? So it's a baclofen pump for pain. And so we do that too for the select patients. And we'll talk about a few cases where we've done that as well. So back to Dalton's case. Remember Dalton from our video. So he was a 14-year-old male. Any questions so far or anything? Okay to continue? All right, let me grab a drink of water. So Dalton was my friend from the very beginning of the video, and thank you to the foundation for giving us that video. They created that for Doctors Day. I was super touched to see it come out, and Dalton's really special. All my patients are, but Dalton's such an awesome kid. He's a 14-year-old that he got this pain after batting at baseball practice. And initially it only affected his left side, and it was kind of hamstring. And, he went to the ER, he did all the things that he was told to do, and he was sent home. He was told it was musculoskeletal. There was no indication to image him. Looking back, I think there were indications to probably image him on that initial ER visit, yet alone it didn't happen. He went to his PCP, continued to complain of pain. He had worsening symptoms that then now became to affect bilaterally. And then he had some saddle anesthesia, right? That was the buzzword that allowed insurance to pay for his MRI. So he finally got the MRI, and then he came to me after suffering for a very long time. This is a kid who was a very high achieving, straight A student, always attending school, did everything he needed to do to be successful, loved playing sports, loved his family, loved God. And now he was debilitated, couldn't do any of those things, could barely get out of bed. He came into me walking over like a 90-year-old man, right? He was hobbling into my room like this, right? He's 14, he shouldn't be walking like that. Physical exam, you guys know what a straight leg raise test is? You do, good. Okay, so straight leg raise test was positive, right? So I'm thinking maybe this kid has a disc. He's describing bilateral radiculopathy. He's got saddle anesthesia. We see this a lot, but most of us don't think about kids having degenerative disc disease because kids shouldn't degenerate, right? We're young, we're healthy when we're 12, 13, 14 years old, but genetic predisposition combined with sports and certain activities does lead to this disease in many, many children. We see a lot of that, but this is what we consider our bread and butter. This is the easy stuff. And at the time I saw him, a lot of his pain and distribution was sort of focused on the right lower extremity, even though it kind of started off on his left leg initially. We looked at the MRI, we saw a large L4, L5 disc herniation, and subsequently, Dalton, who you saw in the video, underwent steroid injections. Look at the size of that disc. That disc is almost causing near total stenosis of the L4-5 level. We don't have any axial views, but he had subarticular stenosis, and the nerve root looked like how could it breathe in there, right? There was no room for anything. So it's simple enough. That same day, and prior to the interventional pain procedure suite, we could have never have done this. But that same day, we were able to take Dalton from evaluation, and we called our X-ray techs, and we sought urgent authorization, and we brought him back to our procedure suite that afternoon at 1 o'clock, and boom, we were able to do this intervention. And so what you're seeing here on the X-ray to the right is a needle percutaneously accessing his epidural space. We're using a little contrast, so it acts like a highlighter to confirm that the medicine I'm about to give is going to be at the appropriate level and have the appropriate spread to hopefully have the appropriate intended effect. Dalton underwent this procedure, and he literally walked for the first time upright in 3 or 4 months. Out of that room, he was very emotional, very happy, which makes me very emotional and happy. He did really well. He had serial injections, so this is not a cure, right? This is a treatment and a strategy to hopefully help him tolerate this pain for the year or so that it'll take for his body to resolve this process naturally. And if he doesn't, right, that's when we think about surgery and surgical intervention. Despite everything, Dalton was validated. He felt like he had a better understanding, which gave him less worry and concern about his future because he didn't know what was wrong, right, before he came to us. So that was a very powerful, that education that he received was very powerful. And then he got pain relief, which was the most powerful thing because it allowed him to return to school. He didn't go back to sports or activities, but he was able to return to school. His symptoms returned a couple of times. He had a few more injections. And eventually, by the end of the year, we think that he re-herniated or had a sort of a worsening of symptoms. We re-MRI'd him, and he subsequently ended up having surgery. But we gave him, which was a validating thing for the surgeons, because if you can imagine how rare this is, how many kids do you know that have had their discs removed or had lumbar fusions because of degenerative disc disease? You guys take care of any of those? Maybe you send them all to us? Yeah. The injections that Dalton received was validating for the surgeons because they saw that not only was he symptomatic at that level, but when we treated that level, he got better. But unfortunately, he wasn't going to make it a year for his body to heal. So he subsequently did have surgery, but he had a much better experience working up to surgery than he would have without. Yeah, I know. I see that. Sorry if I talk too much. I'm passionate about this stuff. This next case is a really unique case, and it's kind of a one-off in the country, and we'll tell you why shortly. Does anybody know what HNPP is? Hereditary neuropathy with liability and pressure palsies. It's a mouthful. Anybody ever heard of it? It's a genetic condition that causes neuropathy, essentially. I met a 10-year-old boy with cerebral palsy, autism, nonverbal, but he communicates with, hand signals, facial grimacing. His mom knows him the best, though, right? She is our number one individual in terms of being able to know when he's in distress, when he's in pain. And myself and one of our nurse practitioners, Lexa, have taken care of him for a very long time. How do we know he had this disease? Well, it's an inheritable condition his mom had. So unfortunately, that's where he got it from. And he started experiencing or demonstrating signs of sciatica at a very young age, right? And mom was convinced that he was symptomatic from his HNPP. So through a very thorough multiple physical exam process, plus parent report, correlated with multiple EMG nerve conduction studies, genetic testing, and MR neurography. Do you guys are familiar with MR neurography? There's special MR protocols that allow us to really detail out the anatomy of nerves and look for pathology. We correlate all of that, and sure enough, everything we had except for this young man, because he couldn't verbally tell us or even point to the area that was bothering him, suggested that he had symptomatic sciatica from his HNPP. So he underwent multiple procedures kind of proving this concept, because ultimately I was working this young man up for possible peripheral nerve stimulation, which is, like I said, a very powerful tool used in a subset of patients. But how do you prove to not only me and to this mom, but to the insurance company that this, multi-$1,000 procedure is indicated in a child for this device was never tested, approved, or even kind of really thought about using. So we did diagnostic sciatic hydrodissections multiple times to prove that those helped. Then when those would wear off, we did continuous sciatic nerve catheter placements, and we would show and demonstrate and write very detailed reports about how much pain relief he would have while the catheter was in place versus when the catheter was out. After all that, we made a very, very strong case. We got rejected several times, but like always, I never take no for an answer. So we did some appeals, and we got a Sprint 60 PNS system approved. And I'll show you what that is in a minute. After the Sprint 60 PNS system failed because once we removed it, his pain returned. He didn't get long-lasting benefit. We ended up moving forward to an implantable programmable peripheral nerve stimulator. And I can tell you this young man is now an 11-year-old boy who's the youngest in the entire country, probably the world. I can say that confidently because I know the reps well, with one of these devices in. So that was done right here at Phoenix Children's. He's pain-free, most importantly. He's off all of his neuropathic meds. He's sleeping well. His family's happy. He's using his assistive walking devices. He's participating in therapies. He's back in school full-time, and it's because of the peripheral nerve stimulator we implanted. So what is a peripheral nerve stimulator? These are peripheral nerve stimulators. The one on the left is the Sprint 60 device. It's a temporary device, very small. We percutaneously implant it, but we remove it after 60 days of therapy. In his situation, because the pain returned, he didn't get long-term benefit. We had to go through that whole process of authorization and appeal again to implant a permanent or semi-permanent device, which is the one on the right. That's completely subcutaneously tunneled in place, so nothing external. And then the battery sits on the skin like a little generator that percutaneously charges the stimulator, and it provides peripheral nerve stimulation to the sciatic nerve and shuts off pain signals and reprograms the central nervous system, essentially. You have to trust me on that. I don't have time more to go into detail. This is an AI version of me, very handsome, performing a sciatic nerve block. AI is great. Notice that this patient has no head or torso. They only have a thigh, and we use bigger needles than that, but you get the point. So this young man got a sciatic nerve block. I can. Which one is that?
The servers one.
Bilateral heel pain servers. Yeah, I can skip that. I'll skip this case. It's another great case, and it's an example of ablation. You have to trust me that we did the injections on this young man. There we are, proof. I'm doing it there. Young man had server's pain, and unfortunately, we can't go into too much detail, but we were able to offer him cryoneurolysis. I'll just show you what this is. Another tool after diagnostic blocks where we were able to prove the concept, right? We put the local anesthetic on the nerve. We shut the nerve down. What happens when the body processes the medication? The sodium channels wake back up and the nerve starts sending pain signals again. Well, in this young man's case, we needed something longer lasting. So we advocated to be the first program that's doing pediatric cryoneurolysis percutaneously in the country. So that's what we're doing. We're using this device called the iovera percutaneous cryoneurolysis probe. It allows us essentially without drugs to go through the skin with ultrasound guided or x-ray guided techniques, find the nerves, put a cold probe on the nerve and freeze them. And after we freeze them, the nerve dies by Wallerian degeneration, and then it grows back over the next 3 to 6 months. So it's disconnecting the pain from the brain for a very long time without medications or injections. It's very safe, and we're utilizing this here at in our pediatric pain patients. And just to reiterate again, everybody gets a block. When I walk into, that's not true. Everybody doesn't get a block, but I think about it for every single patient. So we try to pair our interventional pain practice and techniques with every patient we evaluate, but not everybody's a candidate. But those that are, we try to talk them into blocks because we know that we can use this as meaningful adjuvants to the multidisciplinary approach. And I'm just going to let Jamie take over so we could talk about some other fun facts real quick. Hopefully we'll have time for a few questions.
Yeah, I'm going to talk about a couple of the cancer pain cases that we've done here at PCH, and we're both very passionate about cancer pain and think so much more can be done in that area. So that's why we're bringing special attention to it. When you look at statistics, there are a lot of pediatric cancer pain patients that have intractable pain. 10 to 15% is the estimation, even when managed appropriately with medications, and 10% die with uncontrolled pain. And it's just so sad. But we really feel some of the things we can offer can close a lot of those gaps. What can we do for our cancer pain patients? Several things that we think about. We do peripheral nerve blocks on some of them, and all this is based on what kind of tumor they have, the location of it, what kind of symptoms it's causing, and their comorbidities and goals. So we evaluate all of that, and also what other treatments they're going to be having and how it will affect our procedure. So those are all things we consider. Peripheral nerve blocks, kind of like some of the cases we were just discussing before. In cancer pain, we frequently do sympathetic blocks and neurolysis. So those are things like celiac plexus blocks, hypogastric ganglion blocks, ganglion of impar blocks, or neurolysis. We do epidurals sometimes other types of spine injections. And then intrathecal pump or targeted drug delivery. We went over that a little bit earlier, but basically the premise is you give medication directly into the CSF through a pump, and it allows for superior pain control, but also less side effects because of the microdosing from the opioids and medications. And these are both cases from PCH, so some of you may know these patients. But this patient we met when she was 21, but had been in the PCH system for quite a long time. Her diagnosis was metastatic ovarian yolk sac tumor. That MRI is her MRI. She came to us with very severe abdominal and pelvic pain. Not only that, she was on systemic opioids and could not escalate the dose because those were compounding the situation where she was getting worse and worse constipation, worse and worse urinary retention. The opioids weren't helping. She came to us and said, what I really want is to drive and be able to go do things and stay independent. We talked with her about different options, and she thought about it for a while and came back to us, and we ended up deciding to place an intrathecal pump with the catheter tip at T7. We filled that pump with bupivacaine and hydromorphone, so that's what she was getting infused. And she did phenomenally with that for several months. So she had very well-controlled pain for several months. She was not on opioids daily at that point anymore. She's taking them PRN. The good thing is when you're taking opioids through the CSF in that way, and it's in a targeted area, you don't get that mental fogginess and sleepiness and all those things that you get with systemic opioids. She was alert. She was able to drive and do the things she wanted to do. Unfortunately, the disease progressed, and then at month 4, she came back to us with new pain. She had right shoulder pain that was new, and also these lower extremity symptoms, and we sent her for scans, and she had cauda syndrome and new metastases in several areas. So this is the thing about cancer pain too. You're treating something, but new things may come up, and you may have to do different interventions, and that's what happened here. She went on to have surgery for the cauda syndrome, and then we did several things in terms of blocks. We did a right brachial plexus nerve block for her, which did really improve that shoulder pain, and we did do a chemical ablation of the suprascapular nerve as well in the shoulder. We discussed maybe ablating her brachial plexus, but it's hard because then that arm isn't going to function. But at some point, sometimes that's necessary in these cases. We added also quantity into our intrathecal pump towards the end. And then finally, around 5 months, she did pass away at her home with her family. And, we really felt that our intrathecal pump really did help with that baseline pain and that majority of her tumor burden and the symptoms it was causing in her abdomen and pelvis.
Gave her life back for the last few months of her life when she really wanted it.
Yeah. And this is a patient that's still our patient that some of you may know. We met him when he was 2. He's now 3. But we met him inpatient. His diagnosis is rhabdomyosarcoma of the pelvis. And he was having pelvic pain. And what we were presuming, because he's 2, he can't really talk and explain to us very well, presumed bladder spasm based on his mom's interaction with him and how he acted and how these pain bursts would suddenly come up. He had a lot of different symptoms and surgeries and different things happen related to this tumor and just how it was displacing his bowel and bladder. And he had undergone a lot of different treatments. He had chemo, he had radiation, and the team was trying to control these symptoms as best they could. And they were doing things like bupivacaine bladder washes and medications because the medications really weren't touching it. So that's when we got involved. And we had to think about this in a novel way because some of these things have never been done in someone this age, and some of them never really been done in pediatric patients. So what we decided to do to address the bladder pain and spasms was this inferior hypogastric plexus block and ganglion of impar block. And that was based on, the location of the tumor and the symptoms that we felt he was having. To get to the inferior hypogastric plexus, it's complex. There's a couple of different ways you can try, but he had nephrostomy tubes and other things going on. So we had to come up with a different way to get there because those were in the way. So we ended up going through the S2 foramens in the sacrum and accessing it posteriorly and then going anterior through the foramens into that space. And so that's what you're seeing in this picture from his procedure. So you can see our needle and then that dark fluid right in front of the sacrum is the contrast spread. And he did really well with these blocks. He did well for 5 to 6 weeks and had a significant improvement. And we did this a few more times and they started diminishing in effect over time. So then we're like, okay, we got to come up with a new plan. What do we do now? And so the next thing that we considered doing was phenol neurolysis. So phenol is a compound, it's liquid that denatures proteins and cell membranes, and it interrupts nerve signaling that way. And it can do it for months at a time because it takes months for those cell membranes to rebuild. The thing about it, though, is one, again, these blocks have not been described in this age group, and phenol dosing for this kind of thing, especially in someone this small, has never been described. So we were looking through all kinds of literature trying to figure out how do you even dose this safely?
This is not in open evidence.
No, you can't just Google it and find it. Like, no one's done it and there's no guidelines. So we had to figure it out and figure out what we were comfortable with and what we thought was safe based on PM&R literature for spasticity and adult literature for oncology and all these things. So it was quite a process, but we ended up doing neurolysis on him twice. The first time it was a little bit lower of a dose. We didn't go all the way up to the superior hypogastric plexus. And, he did okay, but it wasn't a home run. So then we did it again in April. And this time we used a little bit bigger dose and we did more targets. We did ganglion of impar, inferior hypogastric plexus, and superior. And then that actually worked very well for him. And we established that this is safe. So this is something we can publish that other people don't have to try to sort this out on their own either. We're getting to the end now, so thanks for bearing with us through this. But, truly this field didn't exist even just years ago, and now we're here building it. And I think our program really is going to be instrumental in influencing and building this field as a whole. We have what a lot of places don't have, which is a dedicated infrastructure where we have everything set up in a very well-oiled machine almost at this point to take care of these patients. We can do advanced procedures that a lot of places can't do, and we have several physicians that will be able to do them. And we're going out there and telling people what we're doing. We're trying to present what we do. We're trying to collect the data. We're trying to really make a push for why people should be interested in this and why they should consider it. So we're working on it on all those fronts. But, really the fact remains that this is very constrained nationally. Not a lot of places have access to this. Not a lot of kids get access to this, but we're really trying to work on changing that. And then just a couple of thoughts here, and then we'll wrap up with another Sean Gamble video.
We all need one more of those. Just kidding. So, our goals moving forward for this program so that we can improve access to all your patients and all the pediatric patients out there that we're clearly not able to treat yet. There's a lot of work to be done, right? We need to continue to improve access. We've done that recently by having some media attention to some of our interventional procedure suite development and patient cases. and all that goes a long way. But doing talks like this and speaking to trainees and the attendings that are virtually online, thank you for attending, to let you know that we're here and we're willing to see and chat with you about any case that you have. 1 in 5 of your patients are going to suffer from chronic pain. So continue to send them to us and we'll evaluate them from a multidisciplinary comprehensive standpoint. And we'll always consider them candidates for interventions if indicated. We're also going to continue to expand advanced techniques. So the things that we're doing that are cutting edge, really, honestly, we're going to continue to do that and be pioneers in our field, which will, I think, give us national and international attention from those that are following in our footsteps, and also kind of building this field with us around the country. And this will help us continue to define our field.
Our team does is it validates the pain experience, number one. And we provide patient education to our pediatric patients and their families, which is very empowering. Chronic pain is a battle. And for these kids, it's the ultimate battle because it takes away their quality of life, takes away their friends, their circles. Phoenix Children's is the only comprehensive pain management clinic for pediatrics and adolescents in the entire state. Kids like Dalton walking out of here today, to see him have such a profound result, it's just a thrilling feeling. And it's awesome to be able to do that for kids. This is why we do what we do. Our team does.
Thank you, guys.
Yay.
We made it to the end. I appreciate you all.
Oh, yeah.
We got one more. Before I click to that slide, I just want to show you guys that it literally takes a village, and this is the village that supports us. And I don't have time to go through everybody's name, and I wish I could leave it up here longer, but we tried to include everybody that supports the growth and development and the future of our interventional and our comprehensive pain management program. So thank you to everybody that helps us be who we are and do what we do. And here's the last slide, sorry. Please get your CME by texting 55191.
We're over time, so anybody who has questions, just feel free to come up to the podium.
And thank you everybody online who joined, and I'm sorry that we went right on to 8:32.
Too much to talk about.
Too much to talk about. And there was a lot cut from this presentation.
Could have
Thank
gone on
you.
another hour.
Yeah, for sure. We'll do it again next week, guys.
I think it's good. I think a lot of us don't realize.
Oh, yeah.
We don't take care of cancer patients and stuff like that. I don't think, I didn't realize you guys were doing all this.
Yeah.
Yeah. Well, that's why we try to take advantage of these opportunities just to share and kind of like brag a little bit. Like, this is what we do. This
It's
is
like
where
it's small. There's
your
just two
patients
of
have
us,
access
so-
to this where they don't anywhere else in the country. You know what I mean? It's unbelievable. And they're not all home runs, and a lot of them are very challenging cases that push us to our limits, right? In terms of like what we can do, what we should do, what's safe for the patient. But I think that's what drives us. Yeah, it's a lot of fun.
I had thought, because I know, I mean, it was Paola who kind of like suggested this going around.
Yeah.
I thought it's, if it was a second one, my mind is a little vague now, but talking about the ketamine. I thought maybe that was going to be part of it here, but where do we see?
We do use ketamine interventionally for end of life. Ketamine is used intrathecally. And ketamine is kind of like on the precipice of like where can it be? It's unfortunately become like gabapentin in the water now, right? Everybody's trying to use it for everything. In pain management, we probably use it as an adjuvant for essentially, thank you, for a lot of intractable cases, right? And especially when there's a co-committed like mood disorder. So we don't have an infusion clinic yet. That's also was one of my sort of goals, was to be the first pediatric program to have an outpatient interventional ketamine infusion clinic for pain. We have the space down in the trauma bay, but we haven't had full support or buy-in from the hospital system yet. Insurers don't pay for it on the outpatient basis. On the inpatient basis, we use it as an adjuvant for the already inpatient, et cetera, for a lot of neuropathic contractile conditions like headaches, migraines, CRPS, sometimes functional abdominal pain, right? Well, because the way we understand functional abdominal pain is it's psychogenic. It's not, right? There's real pain modulation occurring. So we can demodulate with NMDA antagonism. So we use it for those cases. We get great results. Interventionally, we don't inject ketamine in a lot of places unless it's in the blood, because it is neurotoxic when directly put on it. But it makes up a small portion of what we do, but it's a powerful tool. We use it a lot in our sickle cell patients, kind of right out the gate as an adjuvant for opioid sparing, right? Because we've found through the data that gabapentin, those things are good.
Yes, absolutely. I think it's important.
Cheers. Maybe we come back and just do a ketamine talk.
Yeah, or
and
you know,
just a whole.
Chronic pain thought that would be.
And here, we're